were uh, out by the airport, I was really intrigued by your passion and love for what you do, and that's what kept me like. And I've found it, it's very infectiously, to say the least.
Oh, that's nice of you. Turn on a little bit of
Yes.
light in here.
Yeah,
Thank you. I appreciate that. I think we're really lucky to do the work we do.
yeah, no, I understand. Uh, so I've emailed those talking points. So if you like, we can just go over those. And I know we have put aside 1 hour. So whatever we can cover, we will cover. Rest we can do at a later time. Uh, so maybe if we can just start with your thoughts on, say, we all talk about AI and we all know how important the data is or the research information which we get in any kind of AI implementations. So, at Ultimate, based on what you have been seeing, the information which you get either internally through Ultimate systems or from third party systems, what do you see coming in that data? How much do you see aspects of bias baked in or lack of data baked in the information you gather or you get? get.
Well, I think, oh, there's Lori. Hi, Lori.
Hi, Laurie.
Hello.
Hey.
How are you?
I am doing well. Just one moment.
Take your
Let
time.
me let me get a nice cute background on. I love your background, by the way. It is like I love that background.
Yeah.
Mine?
I
Oh,
Yeah.
actually like the train
I mean,
station background that you had too when you were staring at the picture. That was so
oh,
you from the weekend. Mm-hmm.
yeah, this is my dining room. So it's not a background. This is my but
It's
my
the
house
real.
is fun, right? Like I have fun kind of like art and stuff. So,
Yeah,
Oh,
and
are
it
you
was
an artist?
she
I
is.
was a professional muralist before I went into
Oh,
healthcare. And I
oh,
got
nice.
started in healthcare because I got a job as an art therapy assistant in a locked psychiatric setting and was doing a lot of stuff, kind of cleaning and, doing unlicensed work. And the nurses kept saying, you should be a nurse. And I was like, I'd never even considered it before. And then the more I learned about it, I was like, oh, yeah, I do really like this. So now, as a scientist, I use a lot of art based interventions because you have to use a different part of your brain when you're answering things verbally, and you're really allowing yourself some social desirability bias. And this is kind of what we're going to talk about. You know what it is that you want to say in order to be perceived a certain way, and you're not necessarily always being as honest or open about what your challenges are. And when you draw it, you're not as used to lying with that part of your brain. So whether you're doing it to make people comfortable or not, we often get more authentic responses. So,
That's very interesting. I would rather talk about that than the agenda I had put together. So, if you don't mind, and again, I didn't know this background from about you, and Laurie knows me. Anything brain or brain related is my passion. We have worked with a lot of other clients who are psychiatrists, neuroscientists, and so forth. And uh, every time we do those engagement, I learn whole lot about how much we do not know about how brain functions.
oh yeah, yeah. I mean, we are so new as a species,
Yeah,
and our civilization as we know it is so new in this iteration that there's a lot of things we're still figuring out about each other. But we have sort of echoes of the past that continue to influence the way the way we eat, the way we participate, the way we use healthcare. And so I'm a conceptual theorist, which means I do a very 30,000-foot view on problems and problems slash challenges. What it really means is that a lot of people use existing theory to establish how they're going to approach a situation, right? They'll look at like the stages of change, or they'll look at like the socio-ecological model. And I think that's great. What I do is I sort of have an awareness of existing models, but I interact with the zeitgeist, current trends, and I'm able to use those observations and secular events, right? The nuances of how people interact with each other in set environments to do targeted problem solving. So we're not doing abstract theory in healthcare systems. We're saying right now, with who, for what problem, in this contextual moral environment, what's actually happening. And so this is the opposite of building the plane when you fly it. I've said that before to Lori. We make a lot of foundational errors in how we approach things in the first 2 or 3 conversations we have with each other. And if we can be very open about our biases and whether or not we're actually bringing who we are to the table a little bit too much, or not admitting that we're, excluding ourselves from the table, we can avoid some big problems that become multi-billion-dollar problems in a system that you can't iterate your way out of. If you have foundational misassumptions, you're in trouble. So that's basically what I do. And I think that correlates to the conversation and the questions you just had around AI.
Yeah.
Right. We have people building systems who are moving as fast as they can. We're all designed to be nimble in this space. But pivots, no matter how many you do, can't correct foundational errors that are built into the system. And so a lot of what we see around the ethics of AI or inclusion in AI or biases in AI live with the fact that, we're not that old as a species and we have
So,
some flaws.
so I know I'll probably change the whole thoughts I had in mind. Uh, but then let me ask you this. I'm going back to the brain aspect.
Sure.
Whatever little I know, I have understood our society has evolved all through the time. Back in the days, we did not even have phone. When I was a kid, we did not even have land phones. Then we got cell phones, and then we got these smartphones, and now we have apps uh, looking for our attention 24 by 7, which we all talk about how dis, distraction, how big of a distraction those things are. But what I have learned or read is our brain has not evolved with the way society has evolved. The brain still works in the old fight or flight mode, and so those constructs of brain has not evolved, and those are maybe some reasons why we are in this so-called distracting paradigm.
Yeah. I mean, I
Uh,
think the issue here is that the brain is an organ and we pretend like it's not. No one would be saying, has our liver evolved since we have smartphones, right? The issue is that Shakespeare and religious texts resonate across the centuries because the brain is, meat and fat and electricity and some salts. It is an organ. And so when it malfunctions or it, opens up new ways of thinking, we tend to have some sort of uniform response across all of us. Otherwise, we wouldn't be able to connect with each other. But what that means is that things in there that have been useful to us still exist, like the tribalism that makes it very much this is the us and that's the them. Because, we historically used this idea of othering, this like emic edic perspective to immediately determine whether or not you're safe. You just wandered into my space and I don't know if you're one of us. And if you're not one of us, I have to be on guard. That sort of historic compartmentalizing that we did to protect ourselves as a species is alive and well when we're designing new technology. Because the assumption that our group knows what's going on, that we are the baseline, we're the standard, we're what should exist, and everything else is just a weird other that we have to map to or account for, um, persists and is a challenge and is one of the reasons nobody rolls in hoping to be biased. But you just kind of are, right? Who exactly is welcome at these tables? Who's inventing these products? Who's in the conversation? The only research I've done that's sort of gone viral is some work I did when I was at Stanford with Larry Chu. And that was, I was a Medicine X fellow at the time, and I was looking at burnout before the pandemic. And, you couldn't get funding for it back then. Let me tell you, people were like, that's not a thing. That's not a real thing. Because they didn't believe foundationally that providers are a patient population. That's a brand new thought, which blows my mind, because if you walked up to a human and you said, "Are you a human?" and they said yes, is that person a human? Yes, we would all agree that, but we'd agree with that. But as people who've been trained clinically, we've been told to sort of take yourself out of the equation. You show up neutral, we treat everyone the same, etc. My work has been, I really don't think that's even possible. So the burnout dyad is about how there's no such thing as patients and providers, in the way there's no such thing as developers and users. We're all just patients. We're all just users. It's a false dichotomy. And when we create these boundaries between the people who are creating and the people who are using, or the people who are healing and the people who are being healed, we forget that, providers aren't healed. Developers don't really
Yeah.
understand what they want as users. And so when we create these artificial separation barriers, we're respecting sort of that primitive brain that's like us versus them. But at the same time, the damage goes both ways. The users are sort of depersonalized, dehumanized. They're users. Sometimes they're just money. And the developers aren't really recognizing the critical factors of their own personal history and sometimes trauma that they're bringing to the design itself.
Yeah. So I want to go back to that theme, because one of the things that we talked about in a very lively conversation was about this whole foundational part, like because AI and what is being built by people who think they know the other, right?
Yeah.
And then you also really dug into this concept of trust, because trust is a very important foundation. And then you also layer that with not only other, but other who represent the culture and, the other components. So share some of your ideas, about this as well, because I think when you and I spoke last, that this piece of it became one of the important contexts for AI, in terms of, is it doing what it needs to do? Is it meeting the goals, all the way down the line, or should I say up the line, when we think about AI?
Yeah. I mean, I think there's a couple of different angles on that. One is that these models do not grow organically out of the ground, right? Like, these are things that have been developed through input and, the data that's being fed to them, that in theory is guiding them to make certain decisions, obviously in the black box, but very much to solve problems and to save us time, save us energy, all of that kind of thing, without really thinking too much about the process involved in problem solving when it's just humans doing it. Sometimes the thing is not the thing. Most of the time, the thing is not the thing. What we think we're doing isn't actually the thing. So here's a good example. I used to be a psychiatric nurse, and I practiced in clinic, a locked clinic with adolescents. And I remember we did a lot of activities like beading bracelets and necklaces, or like teaching them how to knit small thing. The thing is not the thing. I wasn't teaching them beading. I was testing their ability to sequence. I was testing their frustration tolerance when they pulled it off the tape and all of a sudden their beads went everywhere. We're testing to see where there are spaces that need some support, or maybe there's a vacuum that is the whole reason they were hospitalized in the first place. So when we talk about building these AI models, we're sort of forgetting that it's very much like raising children. You're giving them a bunch of your best version of how you think things should be. You're giving them a ton of data, good and bad examples, and hoping that they'll choose the right path. But I mentioned this to Lori. How often do we agree with how people are raising their children, right? Like, how often do we look around
Never.
and go, yikes? The assumption that we should be doing that any of us are in a position where we should be training systems how to make the best decisions, is egotistical to say the least. So better maybe is to understand that there is sort of this what we've been calling this contextual moral ecology in which these systems live. And that is not just that we have this moral, ethical drive to do no harm at the very least, actually help humanity, try to make things easier, et cetera, et cetera. We should believe that. We should be trying to steer it away from things that we know are categorically unhelpful or unhealthy. But at the same time, the context matters. If you're speeding, you should get a ticket, right? Except sometimes your pregnant wife is in the car, right? Except sometimes your dad's having a heart attack and you were in a place where you couldn't just pull over and call an ambulance. Sometimes there are reasons why you want to break the rules. And as humans, we follow a system of laws because we know in our hearts that at the individual level, we will apply those laws and rules based on the situation and with a ton of flexibility. So we're designing systems that have to make decisions without flexibility, without context, and sometimes without the moral grounding we would all agree in, right? That we'd all agree on. But the challenge is, who is building these systems? Are the communities that they're serving there? Well, I want to just finish what Lori asked. Are the communities that are going to be interacting with them the most invited to that table around how the decision making is occurring? Absolutely not. Where did you get your master's in computer science, right? No. But the community health centers and primary care actually stand to benefit tremendously, but also are going to need a tremendous amount of adaptation and context because the thing isn't the thing.
Right. That makes a lot of sense. So, in your opinion, how would these things like, and I'm lumping few aspects, the bias aspect of the data, and also the equity aspect of the data in a certain populations are not represented well, and the communities or the health workers who are working with the population can plug in the holes about the bias and also the lack of equity in the information.
I mean, I think there's a lot of different directions. The easiest, most straightforward, less conceptual theorist answer is that you have to do local adaptation, even of large EHRs in the clinics that are going to be housing them. And that has a difficult financial ramp up that many community health spaces cannot afford. So you can buy a product out of the box that is relatively adaptable, but the process of adapting is simply beyond the reach of most community health centers, for example. So we're going to have to figure out what that means. I think maybe that means we share the development. Maybe that means there's some intellectual property discussions that occur in order to make it locally reasonable and to use the, the embedded knowledge in the experts who are the people that are living it. So that's a big argument for systemic solutions around contracting and sort of like universal agreements around who owns what and who's actually being collaborative versus extractive in this space. So that's an angle. But the other angle is, why do we keep expecting technology to be better than who we are? It's the wildest thing. It makes the news if a self-driving car gets into an accident. How many accidents do humans get into? Like every single day. The expectation that somehow it's going to be better when we know how biased and racist and, heteronormative and all of that, we know that we're that way. Why are we thinking that with very little time to change our thinking on most of these topics, the tech needs to somehow be better? I think we should assume the tech's not going to be better and kind of go from there and say, given that we know this is a mirror on who we are, what do we know from the state of the science are places that are going to be sore spots or, rough spots that we're going to have to smooth over in situ?
That's an interesting perspective and very nuanced. But given that perspective and what you're seeing happening around you, be it Altamed overall or overall in the communities which you work with, do you see any things which are keeping you up at night, which you think are not going the right way and overall pushing us as a population and community in wrong direction with the speed with which everybody is trying to adopt AI in healthcare systems?
Yes. This conversation is different because I've had a few experiences over the last 2 weeks that have broadened my mind to what does this look like 5 to 10 years from now? And so most of my concern is resting in the what does this look like 5 to 10 years from now? Because you can, in theory, using big data, build out predictive models to the month of when I'm going to have some sort of cardiac event. But that doesn't mean that I'm ready to hear it. And it doesn't mean that I have the agency to make the changes in my life that will be necessary for me to avoid it. And so now I get to live with the existential dread of my own impending cardiac event. I think the technology is moving more quickly than our ability to translate it to human comfort. And there is a lot of horror in the knowledge. Very often you don't want to know. There's actually a classic scenario. It was a study, but it was really a scenario. And I first came across that. I was an undergrad at UCLA, and there was a group that was going to South America to study a certain really aggressive form of early Alzheimer's, early onset Alzheimer's, where you get it in your like late 30s, early 40s. It was completely devastating. And I, lucky enough, wandered into Ackerman Ballroom when the scientist had just gotten back with his crew, and they were reporting out. And the idea was in a small population where families are connected, they know each other's history, mountain tribe, right? And you have a 40-50% chance of being completely bedbound and requiring all of the resources of a community that is, fairly subsistence living. Do you want to know your genetic profile? Right? Do you want to know? Because if you know, other people know. Do you want your 6-year-old to be, an outcast because everyone knows they can't really be friends with them, can't really fall in love with them, can't really take them to dances because this isn't a person that I'm going to be able to have a long-term relationship with, right? What if you just got married and you really want to know if your spouse or you're about to get married is going to be somebody that's going to be totally dependent on you for the rest of the 40 to 50 years they have left of their life in a small mountain town? Is that ethical to even tell them? I don't know. The ultimate solution was that they did the genetic testing, that the small community agreed because they knew that it was tremendously beneficial to just humankind to get access to this knowledge, but they didn't want to know. You can take our blood and don't tell us. And I think we're very quickly getting into a place with the amount of data, just the sheer magnitude of data, that our predictive powers will get us to a place where we're going to have to say, do you want to be blissfully ignorant? Is that okay? Or do you really, really want to know your future? And I think we're not at that place yet. And it will be all the more difficult when we have huge shifts in the things that give our life meaning, like our sense of identity through our work, which is about to be a major shift. So yeah, I have some sleepless nights. I'm worried for us. And I'm really hoping that as we progress, we double down on the humanity of what it means to be here together.
So staying with that example, how do you think the scientists would have thought about this mountain communities' blood samples or the analysis they would do will help the larger population because they're still working with a smaller community of people, right?
Yeah. There's a lot of very big philosophical discussions to have about this, right? You can do trolley problem challenges with it if you want. You can look at utilitarian, like, oh, the most good for the greatest number of people, but it sort of forgets the people that get crushed under the trolley wheels for that purpose. When I teach this, I teach about teleology versus deontology, and this idea of like, is it always right to do the right thing? Or is the context more important than than anything being right. I think there is no capital T truth. That's why I'm not it's why I'm not a philosopher. I'm a conceptual theorist. There are only little case T truths of the things that we can interpret right now in reality together. There is no greater good experienced at the individual level. The sacrifice still exists. So we have to talk about it, because when we receive healthcare, we receive it as a person. And sometimes as a family, sure. Sometimes as a community, sure. Sometimes as a race or ethnicity, sure. But my lived experience is my lived experience. So is yours. So that critical translation is going to be necessary. And I don't see a heck of a lot of folks being invited to the party that are able to use that lens when they're translating this knowledge.
Can you elaborate on that, maybe with some example, just so we know the gravity of this problem more, or people who do not know about it as much as like you're elaborating?
Sure. Are you familiar with the trolley problem?
Uh, Not really.
Okay, that's okay. So there's a philosopher, Philippa Foot, who invented this trolley problem. This idea that, oh gosh, Lori, I hope things are okay. This idea that you have, you're standing next to a trolley line, and on one set of tracks, there is a single person. On the other set of tracks, there are 5 people. Right now, the trolley is barreling down and it's about to crush 5 people. But you yourself are right next to the connector switch, and you can pull it and have the train or the trolley divert and only hit the one person. What do? Do you stand there and do nothing and let it hit the 5? Or do you divert it and let it hit the 1? What do you do?
All right, right.
Right? Now, that answer is helpful, but it's more helpful if I ask you, what if those people in the trolley were your family? Right? What if all of them were convicted murderers, right? What if all of them were healthcare executives, right? What if the person on the other line was a child? The point of this exercise is not to actually have an answer. It's to help you understand what you think about death. Is a big chunk of death the same as a tiny slice of death? Is death sad at the smallest level the same way that it's sad at a genocidal level? These are questions we have to ask in a very silly way when we think about utilization patterns in healthcare. Who gets what when? Who gets the
Right.
appointment? Right? And so when we build out these systems, we're constantly building in ranking, we're building in triage, and we're figuring out who goes first, who goes fastest, what's the most cost effective, right? Our whole value-based care is sort of designed around this. And yet, when I sit in meetings wherever I am, and I'm not representing my current health system, I don't hear people acknowledging out loud, I believe in a big chunk of death. I don't believe in a little slice of death. Right? They're not acknowledging these deep things that they believe, their own personal cosmology about the universe and reality and how we inhabit it. They're just living their lives. And so are our patients. So if you have a patient with uncontrolled diabetes and you've given them lots of opportunities to use the nutrition app that you're offering, or get access to supplemental groceries or whatever, right? But they're not doing it. It may not because the app isn't, streamlined and lyrical in the way it presents its data. They may literally be thinking, si Dios quiere, if God believes that my health destiny was for me to have diabetes, I'm not pushing back against that. That's bigger than me. I'm living my life day to day, trying to do my stuff. So you have a fundamental mismatch between what the provider's trying to push on the technological side and what the patient deeply believes in their heart and how they will behave. Who is at the table bridging that discussion? Are the patients sufficiently educated? Do they have the agency to question the technology and ask about how it interacts with their beliefs? Do the providers have a sufficient knowledge of their local cultural context such that they can ask the right questions? What we're missing is that person that sits between those two spaces. I think we have opportunities. They exist right now. But we need to loop them into the conversations on both sides. And
Right.
It's not fast or cost effective to do so.
Right. Right. Now that's interesting. So based on your experience and what you have seen, what kind of interventions to gather holistic data, complete data, clean data have worked in communities, either in health systems or directly with communities and so forth?
I mean, it's an easy answer, which is that everything is data.
Right.
If something is happening that you're not expecting, or people are missing appointments, or anything, everything is data. So when you take an ethnographic approach, you allow your mind to be open and fluffy and fertile, and you notice things you might not notice otherwise. I have a couple of studies that I did that are really good examples of this, but I'm just going to say it, this one little thing. I was doing an evaluation of burnout mitigation and recovery among community health workers and promotores and medical assistants in a community health system in California, not the one that I'm currently in. And they had rural offices and they had urban offices. So I had the ability to compare the two, and that was phenomenal. The biggest challenge to the recovery of the individuals that were that we noted was that the rates of domestic violence were off the charts, and we wouldn't have picked up on it at all, except we did an art-based intervention that allowed them to draw for us the reason why they were doing what they were doing, and we just simply dug down, just simply kept asking questions, because what we wanted to give them was a mindfulness app. Right? What we wanted to give them was some tech solutions that we could scale across the system. But what we found out was that the tremendous stress in this specific population, the fact that culturally they were living in multi-generational families that had expanded during the pandemic, that many of their spouses had been laid off, that it was a very kind of macho and Marianistic society with set gender roles, where now these women were in a position of power that wasn't comfortable for their family, meant that domestic violence was increasing, as actually it has historically across all pandemics. I don't know if people know that, but
Is it?
yeah, actually, even going back to like Julian plagues, we know that that's true. But
Hmm.
the interesting thing here, and again, this is the everything is data. So my question to the population, after we dug down, and found out this was the issue, was what free and low cost resources are you using that you give the patients when you find out there is a domestic violence issue? And do you know what they said? Would you like to guess?
Not really.
They basically said none, because those are for the patients and we're providers.
Hmm.
So instead, these low wage workers, right, they're making minimum wage to do this, believed so strongly in their identity of being a provider that they weren't open to the resources that they were, providing and espousing for everyone else. And instead, at every paycheck, they were donating money to an envelope that lived in a big file cabinet at the clinic. And if anybody knew that asking for extra money for some reason, for groceries or whatever, was going to cause a fight at home, or if they felt unsafe and they knew they needed to stay at a motel that night, anybody there could borrow money from that envelope and go use it to be safer. So they used their, communal culture experience. They used their understanding of gender dynamics. They used their understanding of, what they knew would be safe, even if they weren't using set resources that they were giving other people, because people are resilient. But my technology, my mindfulness app, was never going to touch anything.
Right.
So you can't
S-
know what you don't know is the answer. Everything is data.
Right. And I believe the way you're putting it is, yeah, we are gathering data based on what we think is right or what our teams or systems think is right, but we don't know what we don't know. So we are probably missing some critical pieces of information which may have larger impact on the overall implementation of the care, and it's not even being gathered even if it exists,
Yeah.
like the
And you know
example you
why?
just.
I was going to say, you know why that is? And I firmly believe this, because technology is populated largely by quantoids, right? You have these people who love quantitative analyses, which I
Yeah.
respect. right? We've all been, I have a PhD. We've all been trained. I get it. And you think you can do a power calculation and all of a sudden it's supposed to make sense. They have been systematically excluded from being able to deeply understand qualitative knowledge, to deeply understand conceptual and theoretical approaches, because we only have so many years in a PhD. We only have so many years in a master's. I had to stay a whole extra year of my PhD to do the type of qualitative training that I did, right? And then multiple postdocs, right? I get it. We can't all know everything. But if there is this systematic devaluation of qualitative knowledge as though somehow it's not data in the same pyramid ranking, it's somehow not as rigorous or relevant, then you roll in assuming the factors you want to measure through convenience or bias, you measure them, and then you launch. And sometimes have a massive misfire. And the only way to correct for this is to say data is data. And at the very inception of a new project, we can't just roll in assuming what we think is going on, especially if you grew up in Fremont, you went to a fancy high school, you rolled immediately to Stanford and then Google, you probably don't know what's happening in the local community health center, no matter how, how well-meaning you are. These are good people. I'm not critiquing them, but none of us know what we don't know.
Yeah, yeah, that's a great point. And based on what you're seeing in how various AI or even any tech systems being implemented at health centers, uh, how well are they integrating with the overall care workflows, in your opinion, especially now with AI coming into picture with what we just talked about, uh, the insights of data being either missing or not being even aware of needs to be there.
Yeah, I mean, again, the theme behind most of what I'm saying is context and hierarchy. I think
Right.
there's a hierarchy between, quantitative and qualitative. I think there is a context between cultural translation and, again, just the situation of the patients and providers themselves. But specifically, when we talk about workflow issues, I think there are hierarchical challenges around the interdisciplinary care plan. I'm sorry, the interdisciplinary care team itself, because a care team is generally seen in the hospital as a physician and nursing staff and potentially, physical, all the therapies, physical therapy, occupational therapy, social work, pharmacy, all those folks. Historically, in community health, you need a provider and a patient. You often don't have registered nurses, or you have very few. So there's a huge gap in that hierarchy between the physician leader and then the medical assistant, for example, or the LVN that is supporting them. And so you have the people that are being asked to inform the design of a lot of these different products who are with the patient for 15 minutes. Right now, it's true. It's very important to their pajama time that, ambient scribes make sense to them, and that these things are really useful in protecting them in ways that allow them to provide to the best of their skills. But the actual implementation lives with the nursing staff and the allied health providers who are not part of these conversations in any real legitimate way. Until very recently, the American Nursing Association is starting to work with CHI and some other groups to make sure that they are included, not simply as end users, but sort of as workflow architects. They also need to be, burnout innovators, because there is a lot of burden associated with new tools, even if it's just the learning ramp up that you need to do. And then they also need to be safety validators on the back end. We need to be able to see in real time how this played out when the patients used the technology, or we did, and then be able to give feedback that allows for improvements and pivots, right? But if you're not being invited to the initial conversation, you're not being included in a lot of sort of the checks and balances that are occurring. You're not being explicitly asked, why didn't this work? What's your opinion? Then the systems are never really going to line up with reality. And we're always, all of us, going to be doing back-end corrections that may or may not make it time-saving overall. So context, hierarchy, inclusivity, I think have always been the problem. tech just sort of brought it back to the forefront. But we know that about ourselves.
Yeah. So let me ask you this, and again, I'm talking based on my personal experience of, we all have gone to doctors and seen how they work. They follow a very regimented workflow. They will have you go through a PCP, and then they will refer it to someone. And I've gone through multiple ways to tackle, say, one or the other problem, but I always feel nobody is dialing down to figure out the root cause of the challenge, whether it's the way I'm eating, whether the way maybe my sleeping habits or my stress level. They are just very regimented. Okay, do A, B, C, D. Otherwise, go do this test and do that test. Uh, so how will you? So that I always feel that holistic aspect is always missing, either because of the way payer provider relationships are structured or just the way they have been told, either because of liability or something along those lines. So how will you bring in this holistic aspect back into healthcare, not just management of your symptom?
I mean, I believe that that's the hope. CMS pushing value-based care probably a little sooner than we were actually ready for it is the hope that the 5% of healthcare expenditures, 3 to 5% that go to primary care, preventive care, is misaligned. We shouldn't be spending 95% once people are actually, living with chronic illness or have some sort of catastrophic event. So I think we all know that it needs to happen. But foundationally, what needs to change is we have to stop believing in the health belief model when it's been widely discredited for decades. The health belief model is if people know better, they do better. And that's just not true. I have habits right now I could tell you about that I know absolutely are not good for me, but I'm still doing them because they're kind of harm mitigating, right? I'm like, well, it's better than this. You can't just assume that educating people or giving them access to things is what changes their behavior. That there are just too many other, again, contexts. And the context is situational. It's, it's moral. It is deeply about where they are in their life course. It's geographic. I mean, yeah. So I think the holistic perspective is what you get when you include nurses in the conversation, because we are not Western biomedical model focused. I don't know if you know this, but we're a completely different scientific tradition that believes in holism. So we actually believe in removing the body's barriers to healing itself. That's one of the things. And the other thing that we believe is that we are here to help patients live the best version of their lives, their version, right? Not my version. And so if your version includes fast food and cigarettes, I'm not telling you that you're an abject failure if you're doing that. I'm trying to work with you to make it, less dangerous, less risky, augment other parts of your life. Our systems right now are built on the Western biomedical model. If we give you the right knowledge and access, we assume you're going to do better. I don't know why the system would be any less flawed if we just, involve data, put it on an
Right,
app.
right,
We know it
right, right.
doesn't work. So, there's big challenges. It doesn't mean we should slow down or stop from this direction, but you're right. I'm really hoping that the change happens at the policy level, that we get financial incentives, technical assistance, things that allow us to really say, if we are doing value-based care, which by the way is not about money, it's about what the patients value. That's
Right,
right.
right.
That's where that comes from. So if we're respecting that ideology, how do we know patients better and design systems around real humans as opposed to our convenience? I think that's the big challenge.
I'm out of questions because I'm out of thought. There was so much I got to learn, and this was uh, very, very, very insightful. Like I said, I'm always impressed by your passion and energy you bring to the table.